cellular regulation lecture. The concept definition. So all functions carried out within a cell to maintain homeostasis. So this means that cellular regulation occurs in every single cell in your body. It's how your body functions. It's necessary to normal function within the body and maintain homeostasis, replication, and growth. So this meaning that the cells are replicating, they go through, if you remember back from your biology courses, that cell cycles go through like mitosis, meiosis, differentiation. So some of these terms are listed down below that you should be familiar with. Proliferation, meaning reproduction of new cells through cell growth and divisions. All right, so that's like basically like multiplying. Proliferation is like multiplying. Differentiation means that the cells now have been assigned a specific role. So they have a specific function. They are certain cells that are to be placed in certain parts of the body, so different organs. So they function differently based on where they are located in the body. So they're kind of assigned their own role with differentiation. Neoplasia. So neoplasia means that this is abnormal multiplication of cells, leading to the formation of a neoplasm or a tumor. So in other words, malignant cells. So neoplasia means that the cells are now becoming abnormal and they are sort of replicating at their own pace. They are not being controlled by DNA, and they are starting to form malignant cells and possibly tumors, malignant tumors, and so on and so forth. So the scope of the concept. So we have normal cell growth. So that means that the cells are proliferating at a rate that they should be. These cells are able to differentiate themselves depending on where in the body they're supposed to be and what functions they are supposed to carry out. All right, so this is your normal, healthy cell cycle where your cells are functioning as they should be. Dysplasia is when the cells have a variation in size, their shape, and their appearance, so they look a little bit abnormal. And dysplasia is also signifying that the DNA has lost control over differentiation. So different causes of dysplasia could be like stress on the body, big infections, that there's some sort of cause to dysplasia. And sometimes if that cause is removed, the dysplasia will be reversed. So dysplasia is reversible, but it is sort of a precursor to malignant neoplasia. So if one then progresses to malignant neoplasia, as I explained before, this is when you are, worried about cancer cells and abnormal replication of cells that the DNA has lost control over. These cells are oftentimes immature. They do not have their differentiation, and they are not reversible at this stage. Populations at risk. So minority groups are at risk due to obstacles receiving health care. So if they don't have great access to health care, they may not follow up with their, regular PCP visits, they may hold off on physical exams, getting their labs drawn, etc. So they would be at risk for not really taking care of themselves as adequately as they should be. Age. So age really varies. Cancers occur at all different stages in one's life. But as you do get older, you are exposed to more risk factors, which could elevate your risk for developing cancer in your life at some point. And it's actually estimated that in this day and age, surprisingly, they estimate about 39% of people born today will experience cancer at some point in their life. And that's pretty scary. 39% is a lot. But it can happen basically at any time in their life. Smoking. So smoking is basically, hazardous material that you are bringing into your lungs, which can cause abnormal cell growth in the lung tissue. And the effects that it has in the overall, body system with like the cigarette smoking and the nicotine, and all of those harsh effects in the body system can result in abnormal cell growth. Infectious agents. So people who have Hep B, Hep C, that they have abnormally functioning livers. So their cell replication in the liver is abnormal, which puts them at risk for developing, different types of cancer, abnormal cells in the liver. Human papillomavirus. So this is HPV. So this would be in the reproductive tract. So, one of the more common areas for dysplasia to occur is actually in the cervix and also in the respiratory tract as well. But with the HPV virus, when someone has that is abnormal cells in the reproductive tract. So having those abnormal cells puts people at higher risk for neoplasm. And then Helicobacter pylori, so that's also called H. pylori sometimes, if you've heard of it that way. So that is in your gut, so that's like in your GI tract. And again, abnormal cells, which can lead to development of neoplasm. Genetics plays a role. So when you hear of certain genes that are tumor suppressor genes, such as the BRCA1, BRCA2, so BRCA1 and BRCA2 have been found to be associated with a higher risk for developing breast cancer. Radiation, so treatment with radiation. So for instance, people who have cancer somewhere, have a tumor somewhere, and they've had their radiation treatments. Well, that radiation harms all the cells in that area. So if it's harmed all of the cells in that area, there is a risk for cells being damaged and therefore resulting in abnormal replication. And also exposure to radon gas, sun exposure. As we all know, UV exposure with the sun puts you at higher risk for skin cancers. And also exposure to carcinogens. So again, that would be your smoking. That could be primary smoking or secondary hand smoking, exposure to asbestos, and there are also other chemicals too, things like alkalizing agents like formaldehyde and benzene, which is in gasoline. These sort of things, if you're exposed to them over a period of time, put you at higher risk for abnormal cell replication. So your assessment, looking for a history of possibly finding a new lump, mass, or lesion. And also when we're talking about leukemia and lymphoma today, you'll notice that a lot of the clinical manifestations have to do with enlarged lymph nodes or enlarged liver or spleen. So things that have become enlarged or have a new lump, something that is abnormal. Alterations in body function. So if they have decreased appetite, if they're having difficulty swallowing, maybe having trouble with elimination, having trouble urinating, all these things can sort of point you in the direction of, should we evaluate this person for some sort of mass that could be obstructing, for instance, swallowing. So if there's a mass in the chest wall that's pushing on the esophagus, they're going to have trouble with swallowing. So that's why those two things go hand in hand. Examination, so visible lesions, so looking for visible lesions, any abnormalities in the skin, any palpable masses, again, enlarged liver, enlarged spleen, any enlarged lymph nodes, abnormal sounds with auscultation, presence of blood in the pelvic exam or blood in the stool. So this would possibly alert you to an abnormality in their level of platelet count, right? So we'll talk a lot about that today with thrombocytopenia. Diagnostic findings that you can do, such as x-rays, so visualize if there are any masses, colonoscopy, endoscopy to look in the GI tract, also MRIs. Okay, other things that could possibly be done as well would be like your self-breast exams for like breast cancer, different skin exams, like following up with your dermatologist, and if there's an abnormal lesion, then going further for pathology. So pathology will examine the cells and the tissues. So pathology can be done for things like I mentioned, the skin, or it could also be like your pap smears, or if you send a biopsy of tissue, if you take a bone marrow aspiration and you look at the cells in the bone marrow. So all of that will tell you what the cells or the tissue appears like. Is it normal? Is it abnormal? Is there abnormal growth occurring? So pathology can tell you a lot about the cells or the tissue that you're examining. Different labs, so CBC, complete blood count, also your chemistries, and tumor markers can also be done, to assess if someone has high level of tumor markers indicating that they have a tumor somewhere in their body, that there's sort of like abnormal release of these tumor markers when there's higher or when there's evidence of tumors within the body. That's what I'm trying to say. Your grading and staging. So grading is the measure of the degree of differentiation of a neoplasm. All right, so remember, differentiation means that the cell should be kind of specific to a certain role, right? So wherever it's located in the body, it should look like it belongs to that organ or to that specific tissue. It should look sort of symmetrical with what other cells are there. So when you are looking at the grading, you're looking at how different those cells look in that tissue. Okay, so how abnormal do they look? Your staging. So with solid tumors, you can do the TNM classification system. So that will look at the stage of the disease, so the tumor size, how many nodes are involved, and if it has metastasized somewhere else in the body. So your clinical management, primary prevention would be smoking cessation, right? So to kind of get rid of any of the risk factors that are modifiable. So smoking cessation, avoid or limit UV exposure, sun exposure, or wear your protective sunscreen when you're out in the sun. Regular exercise. They do recommend that daily exercise will help to keep, all of the cells sort of normal within your body. Everything is sort of optimized when you are exercising regularly. And also a balanced diet. So as you can see there, it says 60% of all cancers are related to this. Isn't that pretty crazy? So 60% of cancers are related to an unbalanced or unhealthy diet. That's a huge percentage. So that would be things like limiting or avoiding processed meats or processed foods, different foods like that are high in fat, like animal fats, or high in sugar, or excess intake of alcohol. So all of those things are considered very risky for the development of cancers. So that's pretty amazing to me. Secondary prevention would be your screening. So that would be like, your annual mammography for breast cancer, colonoscopy for colon cancer, just basically keeping up to date with your PCP visits and following up with any sort of preventative screening that is recommended for that age group. Collaborative interventions, so depending on the type of cancer that you may have, surgery may be an option for treatment, radiation therapy, so that's using the very sort of heavy or strong X-ray to sort of kill off the bad cells in the body that are causing the neoplasm. Chemotherapy would be your pharmacologic treatment. So chemotherapy is really, really strong medication that will target, cancerous cells and help to kill off those cancerous cells, but also affects all other cells in the body as well. Hormonal therapy. So hormonal therapy can sometimes be used in like your breast cancers or some type of cancer that is hormone driven. So they can give hormonal therapy to kind of suppress the hormones that are causing this abnormal cellular replication. Targeted therapy, so that's another therapy that's more specific to the area that is involved. Biological therapy, bone marrow cell transplant or stem cell transplant as well, which we're going to talk a little bit more about in a minute. Interrelated concepts you can see are listed here, and we'll kind of get to see why all those concepts are interrelated in a few moments. Leukemia. So leukemia is uncontrolled proliferation of white blood cells. Okay, so proliferation meaning replication. So it's uncontrolled, meaning the DNA no longer has control over this replication that is occurring or proliferation that is occurring. All right. So in leukemia, cells are often immature. So they're kind of replicating in a way that they're cloning. So they're kind of cloning the cells that are just sort of like popping up, and they keep replicating and replicating. And what they do is they sort of infiltrate or take over all of the space in the bone marrow. Okay, so there are so many that are created that it takes up all the space in the bone marrow, and it ends up spilling out into the circulation. So when these immature white blood cells spill out into circulation, they start to kind of take over the normal functioning white blood cells. And if those normal functioning white blood cells are taken over, and now we have more immature white blood cells than we have mature, our immune system is not going to be able to function normally. So that's why they end up with such a high risk for infection, because of all these immature white blood cells. Another term that you might hear of is something called a blast cell. So sometimes blast cell is talked about with leukemia, and that simply means that it is a immature cell that really does not have enough characteristics yet to determine even what type of cell that is. So that is a really, really immature cell, and it really has no differentiation. Okay, so that's a blast cell. All right. So the cause of leukemia is really not known, but they have found some link to genetics, having a family history, and also some viral influences. So different viruses, if you're exposed to, for instance, like the Epstein-Barr virus, there's maybe a slight risk that you develop leukemia at some point in your life. But they really haven't found the true cause. Bone marrow damage from radiation exposure. So I mentioned earlier the benzene, so that's found in things like gasoline, and also alkylating agents, which would be your formaldehyde. So that can damage your bone marrow. With leukemia, we sort of put them into categories. There are 4 different types of leukemia. So they're either going to be acute or they're going to be chronic. So acute develops rather quickly and the disease progresses rather quickly. And then chronic kind of happens slowly over time, over a period of years. So it's acute or chronic, and it also is determined what type of cell it affects. So the lymphoid or lymphocytes are one category, okay, so that's referring to the stem cells that produce lymphocytes, or the myeloid, which would be basically all the other cells in the bone marrow except for the lymphocytes. Okay, so that could be your red blood cells, white blood cells that are not lymphocytes, and also your platelet counts. Okay, so myeloid is basically all the other cells except for your lymphocytes. So leukemias are either acute or chronic, lymphoid or myeloid. Just an overview of symptoms. So these are sort of your common symptoms listed here in the little picture on the right. All right, we have things that are called your B symptoms. So your B symptoms would be your systemic symptoms there, like your weight loss, your fever, your frequent infections, and possibly night sweats. Okay, so those are called like your B symptoms. But you can also have, clinical manifestations and symptoms all throughout your body. Because think of what is happening in leukemia. It's all the cells in your bone marrow that are then coming out into circulation are circulated all throughout your body. So people may end up with infiltration or sort of an overabundance of immature white blood cells in certain areas of the body, like the liver or the spleen. Also in your bone marrow, when you have all those cells replicating in sort of the mass of the bone marrow, or the size of the bone marrow, I should say, sort of expands, people may complain of bone pain, joint pain, okay? They can feel the sort of achiness that's occurring from expanding bone marrow from all those cells that are replicating and taking up the space, okay? They may also have issues with their bleeding. And again, that's due to the abnormality of the bone marrow function. So you might see evidence of bleeding, like bruising, easy nosebleeds. They notice that they're just getting bloody noses out of the blue. They may have petechiae, like those little tiny pinpoint red dots all over their body, signifying that they have a problem with clotting. All right, so a lot of these symptoms are related to the direct effect that leukemia has on the function of the bone marrow and the immune system. All right? Neuropathy can occur, so you can see enlarged lymph nodes. These are rather large in the axilla here. Okay, so they're very big. And then this person also has an enlarged liver and an enlarged spleen. So talking about how do we sort of diagnose leukemia? Well, we have to look at the bone marrow, see what these cells look like, what is happening. So we can do a bone marrow aspiration. So this means that you basically take a sample of their bone marrow. Oftentimes it is from their hip bone, posterior iliac crest. Sometimes it can be taken from their sternum, but you take a sample of their bone marrow and send it for a biopsy and pathology. So when patients have to undergo a bone marrow aspiration, you want to be sure that you have evaluated their risk for bleeding beforehand. So you want to know what their platelet count was before they have a bone marrow aspiration. And you want to avoid any medication afterwards that could increase risk of bleeding. And then you also want to evaluate their risk for infection. If they have low neutrophil count or low white blood cell count, you want to know what their risk is, because this is an invasive procedure. So when the patient has this done, the sort of standard of care afterward is once the needle is withdrawn from the site, you want to make sure that you hold your pressure, again, kind of having to do with the bleeding, so you hold your pressure until homeostasis has been achieved, okay? So maybe 5 minutes. And then once that is through, you know that there's no bleeding, you apply a sterile dressing. Okay, you really don't want to sort of cause any infection in that area. Another thing with bone marrow aspiration is it can be uncomfortable for patients. So you want to educate them that they might have some mild discomfort for about a day or so after their bone marrow aspiration. And during the procedure itself, it may feel like a lot of pressure on that area, wherever the site is, may feel the pressure of the procedure. And when they actually withdraw the bone marrow, they might experience a sharp pain as well. So you want to educate the clients beforehand that this is what the expectations are of this procedure. All right, so those are kind of the main things. So educating your patient about the procedure, okay, including the discomfort and the pain that they might experience. You want to know their risk for bleeding, so their platelet count beforehand. You want to hold pressure at the site for about 5 minutes after the procedure is done. Okay, you want to avoid any medications that are going to cause bleeding after the procedure. And then you're also going to monitor for signs and symptoms of infection, their risk for infection. You're going to put that dry, sterile dressing over it when it's all complete. All right, and this can be done in the back hip bone or posterior iliac crest, or sometimes even in the sternum. So just reiterating, the big complications are infection and bleeding, and you're going to find that to be a common theme throughout this whole entire lecture. Infection and bleeding. So just jumping into the different types of leukemia, this is kind of just a little graph just to visualize it, but we'll go through each one here. So I told you it's either acute or chronic. Okay, acute is that rapid onset, and it also progresses really rapidly as well. Chronic leukemia is sort of a long-term, chronic, slow progressing disease. Okay? People can live with chronic leukemia over many, many years. And sometimes they may not even have any symptoms that they have it. Sometimes chronic leukemias can just be accidentally found on a CBC at their PCP visit. So most leukemia cells are fully mature with the chronic leukemia. Okay, acute leukemia is more very immature cells that are replicating fast. All right, we're going to kind of go through the different leukemias and talk about the general signs and symptoms again that were listed a couple slides back. So your acute lymphoblastic leukemia, or ALL, is typically a pediatric form of leukemia. So affects children, and as stated in its name, it is acute, and it affects the lymphocytes in the bone marrow. Okay? So it has a rapid onset, and it has a rapid progression of the disease. So your signs and symptoms are kind of everything we went over a few slides back. So weakness, decreased energy, recurrent infections, bleeding that's unexplained, pallor, weight loss, bone pain. They may have night sweats, a sore throat. All right. So with the ALL, they are at risk for something called leukostasis or blast crisis. So remember blast cell that I had mentioned before. Blast cell is when they have immature abnormal cells that really don't have any sort of differentiation. All right, so they have these immature cells that are just circulating, they don't have a role, and they're just kind of taking over the circulation, taking over the cells. So with leukostasis and blast crisis, patients are at risk for these cells like clumping up in areas where they shouldn't and end up with decreased perfusion. So that could be things like poor perfusion to the brain, or sorry for my dog barking in the back if you can hear that. So decreased perfusion to the brain, so like cerebrovascular accident, or possibly an MI or a PE. So these can clump up and cause poor circulation, which would be a life-threatening emergent event. So that's why I wanted to put it in here. So risk for leukostasis, blast crisis, means that they have these high amounts of these blast cells circulating in the body, and they're at high risk for those blast cells to sort of conjugate or sort of build up in areas where they shouldn't and cause issues with perfusion. If any of you have ever seen My Sister's Keeper, it's a movie about a child with ALL and kind of just what the family goes through, what the child goes through, and the parents ended up conceiving another child so that they would sort of have a match, in terms of the bone marrow and all the cells and tissues, so that they could basically help to treat their child with leukemia. And it's a really interesting and kind of sad movie, but if you've ever seen it, that's a prime example of ALL. All right, and if we're in class, I could show you this little clip here, but feel free to watch it on your own time at home as well. ALL, chemo has improved the prognosis. They have a very, high rate of curing and being in remission. There's about 50%, And then there are instances where they will sort of, what's the word I'm looking for? I can't think of it just to save my mind, where it will come back, but that's kind of rare with this type of cancer. So it can be cured, which is good. They oftentimes have combination chemotherapy. Their survival rate is pretty high for this type of leukemia. They will sometimes have to get intrathecal administration of their chemo. So that just means like through their spine, just because of the population, the age population that this type of leukemia affects. So AML, so acute myeloid leukemia. So acute meaning it's abrupt onset, and it also progresses fairly quickly. And myeloid meaning that this type of leukemia is affecting the other cells in the bone marrow, which would be like your red blood cells, the white blood cells that are not lymphocytes, and your platelets, okay? So this type of leukemia can affect basically any age group, but their sort of common age that it is diagnosed at is 67 years old. Okay, so it's rarely seen in children and young adults, but there is a possibility that it could occur because any age group could be affected. Prognosis is variable, okay? They will undergo aggressive chemotherapy, and they may also have to undergo things like a stem cell transplant, okay? Complications of AML are bleeding and infection, which are major causes of death. But that is, again, going to be a common theme throughout this entire lecture. And same thing with AML. They are at risk for leukostasis or blast crisis with AML as well. So your CML, so chronic myeloid leukemia. So again, chronic is over a long period of time, okay, slow progression. And then myeloid meaning it's in other cells of the bone marrow other than the lymphocytes. Okay, so it's in the myeloid stem cell. So a wide spectrum of cell type exists within the blood, from blast to mature neutrophils. They have uncontrolled proliferation of cells. And again, the marrow expands and can cause the bone pain and the joint pain that occur when the bone marrow has expanded from the uncontrolled proliferation. And also, it can sort of clump together or infiltrate or sort of have too much in one area and cause a enlarged liver or spleen. Okay, so the clinical picture of CML is variable. CML is oftentimes described as having 3 stages. So the sort of basic or first stage would be your chronic phase, which is asymptomatic. Remember I mentioned earlier, patients may not even know that they have leukemia until they go to a PCP office and then find out that they have abnormal white blood cell counts and accidentally pick it up by CBC. So your chronic phase is asymptomatic, really no symptoms. And then it can progress to something called the accelerated phase, which they start to show signs and symptoms of those B symptoms I mentioned. So that weight loss, fever, decreased appetite, night sweats. Okay, so they start to have sort of those common leukemia symptoms. And then there is actually an acute phase of CML. And unfortunately, if someone gets to this acute phase, which is also called a blast phase. This is considered terminal. So with the blast phase or the acute phase, they start to have extremely abnormal platelet counts, and they're going to have bone damage and also the enlarged organs again, the liver and the spleen. So when someone is in this blast phase, they really will need some aggressive care, but their prognosis is so poor that they might even just end up talking about palliative at that point. All right. So again, risk for leukostasis or blast crisis in the acute phase of CML. That's your terminal phase. So that's when the blast cells are greater than 100,000, right? And they're at risk for problems with perfusion. All right, so your treatment for a CML is pretty aggressive. They can get chemo with something called Gleevec. That's a chemotherapy medication that's listed. You'll see it in a few slides. They can also get interferon alpha or interferon A and stem cell transplant as well. And then you have CLL. So this is your chronic lymphocytic leukemia. So chronic meaning prolonged progression, slow onset. Lymphocytic meaning that it affects the lymphocytes in the bone marrow. Okay? So it usually affects older adults. As you can see here, the average age at diagnosis is 72. It's the most common form of leukemia in the US and Europe. Family history of CLL is probably the biggest risk factor for developing it, but also those who are exposed to Agent Orange back in the Vietnam War were found to be at increased risk for CLL as well. Patients can survive more than 20 years with CLL. Again, it's slow, it's chronic. It really is sort of, I don't want to say a silent disease, but again, patients can go without knowing they have it for periods of time until it's accidentally picked up by CBC or symptoms start to develop. So these signs and symptoms of CLL is sort of the overall signs and symptoms we've been talking about. So the weight loss, they're fatigued, they may have decreased appetite, they may end up with a enlarged lymph node or enlarged spleen and recurrent infections, and also could be at risk for DVT and clots, when they're further along with the progression of the disease. Treatment, they may not need any treatment initially, depending how slow the disease is progressing, but they can also receive chemo and undergo a bone marrow transplant. All right, so this is kind of what I just mentioned. Early stages may require no treatment, and then they may progress to chemo, possibly monoclonal antibody therapy, and bone marrow transplant. So your pharmacology. So allopurinol. So allopurinol can be prescribed when the white blood cells are being destructed. They release uric acid. So probably thinking way back to, I'm guessing, 1020, where you learn about like renal calculi and everything. Uric acid crystals can cause renal calculi, and uric acid can cause like the gout, in the joints. So allopurinol can be prescribed to sort of get rid of the uric acid in the body that is occurring from the destruction of white blood cells. Okay, so when the white blood cells and immature leukemic cells are being destroyed, that's when your uric acid is being released into circulation in the body. So that's why allopurinol might be prescribed. Hydroxyurea can control the proliferation of white blood cells, and it can cause myelosuppression, but it is reversible. And then your Gleevec. So Gleevec is that chemo medication that I had just mentioned with the CML. And Gleevec can help inhibit the translocation, create an enzyme, and blocks the rapid growth of white blood cells. Okay, so it helps to stop all of that rapid growth and proliferation of these immature leukemic white blood cells. You can see the side effects listed here: fluid retention. So fluid retention, they might have edema, GI upset, hematological toxicity, and hepatotoxicity. And with Gleevec, they are at risk for something called tumor lysis syndrome. So tumor lysis syndrome means that, when these white blood cells and immature cells are all being damaged by this chemotherapy, they can end up releasing all of their internal contents of the cell. So remember, there's intracellular components of a cell that we have, like certain amounts of potassium and phosphorus and etc. within the cell. And then we have another smaller amount circulating in the body outside of a cell. Well, when these cells are damaged or sort of killed, when you think of lysis, right? So that's killing the cell. Tumor lysis syndrome will develop because all those intracellular content is released into circulation. So that may put patients at risk for hyperkalemia, also hyperphosphatemia. All right. So with this, they would then be at risk for cardiac dysrhythmias. They may end up with renal failure. So it's really important, if we notice abnormal lab results such as hyperkalemia, hyperphosphatemia with a chemotherapy treatment, that we should be wondering if they are experiencing tumor lysis syndrome. And that would be very important to monitor. And in that case, we need to basically hydrate the patient, follow their electrolytes, look for adverse effects on their cardiac rhythm and their renal function, etc. All right, so risk for infection. So this is right from one of the books. So patients should recognize that they are at risk for infection, should be educated about their risk for infection. So they should be able to tell you their signs and symptoms of infection, why they're at risk for infection, how to monitor for signs of infection, who should they tell if they have signs and symptoms, ways to prevent it. So you can see listed here, good hygiene, good hand hygiene, maintaining skin integrity, avoid cleaning areas where they could be exposed to bacteria. All right, so like litter boxes, working in a garden where there's like fresh soil, fresh flowers, so that can harvest bacteria and organisms that would severely harm patients who are at risk for infection, especially if they have neutropenia, which would be classified as, a neutrophil count less than 500, or if they're receiving chemotherapy, sometimes considered a neutrophil count 500 to 1,000 is neutropenic. So we have to be aware of that. High calorie, high protein diet, intake of fluid of 3,000 mLs, avoid infections that people are sick with, or avoid crowds. Sometimes you see when patients who do have low neutrophil counts are out in the public, they oftentimes will have, a mask over their mouth and nose, possibly even wear gloves as well. Incentive spirometry, and also, if they are going to have intercourse, to be sure that they have adequate lubrication, because that can alter the mucosa in the reproductive tract if it is dry. So if they accidentally hurt the mucosa there, then that's an opening for infection. Okay, so these are things that you should be aware of, that you are educating your patients about who are experiencing leukemia or treatment for leukemia, and they're at high risk for infection. Risk for bleeding. So again, common theme here, infection and bleeding. So educator should teach the patient about the function of the platelets and clotting factors. So oftentimes these patients with leukemia have abnormal platelet counts, and that's why they are at risk for bleeding, because their platelet count is really, really low. So they should be able to verbalize the rationale for the risk. Okay, identify meds and substances to avoid. So that would be medications that increase your risk for bleeding, such as aspirin, and also alcohol increases your risk for bleeding. Demonstrate how to monitor signs of bleeding. So how would you do that? You'd look for unexplained bruising. Maybe they notice that their eyes look more bloodshot than normal, or their gums are bleeding when they brush their teeth. They notice this rash all over their body that's little tiny red dots, like petechiae. So these sort of things patients should be educated about, so that they know how to monitor for signs and symptoms of abnormal clotting process. So who do they report that to? Okay, if they're having dental work done or an invasive procedure, they need to tell that person that they have thrombocytopenia, they have low platelet count, so that way, they could be sort of taken care of a little bit more, what's the word I'm looking for? Like closely, like watched a little bit more closely. And, for instance, if you're having an invasive procedure, they know to hold the incision site a little bit longer than normal because you're at higher risk for bleeding. So that sort of thing. So describe appropriate ways to prevent bleeding. So you can see all of them listed here. I know we've talked about this in other classes as well, like avoiding your contact sports, anything that's really physical, use electric razors, soft bristled toothbrush, avoid constipation, right? So they might be on a stool softener, that sort of thing. Okay, so they should really understand why they're at risk for bleeding. It's because of the abnormal platelet counts, and why or what are they looking for to show them that they are worsening or really exhibiting signs and symptoms that their platelet count's getting dangerously low. And then say they do have a dangerously low platelet count and they come in the hospital for it. What would you anticipate we're going to do for them? Well, they're probably going to be receiving a platelet transfusion, right? So you can get that. It's like a blood transfusion, but platelets. Okay, so if their platelet count drops really low, usually below 20,000, then they are going to receive a platelet transfusion to help bring those platelets back up and get normal functioning platelets circulating in the body again. You might limit things like IM injections, again, educating them, soft bristled toothbrush, don't let them use a regular razor, anything that you can do to sort of keep them safe, fall prevention, all of those sort of things, okay? Case study here is not mine personally. This was a different instructor's, but it is pretty interesting just to sort of read through. So 28-year-old prisoner, no history really, had an altered mental status in prison. He was not responding, was incontinent, eyes deviated to one side. Some reports of right-sided weakness and a complaint of a headache. He went to a local hospital where a head CT showed several metastatic foci with surrounding edema, with one lesion with surrounding area of hemorrhage. So his white blood cell count, look at this count when he came into this hospital, was 674,000. And what's the normal of a white blood cell count? Less than 12,000, right? So this is extremely, extremely high. Your platelet count, that's okay. But he also had a enlarged spleen, splenomegaly, and they sent him to a larger hospital. So he ended up being intubated for airway protection. MRI showed multiple large lesions. They got a hematology and oncology consult. They had done a bone marrow aspiration. So remember, this can be done to sort of look at the cells within the bone marrow and kind of see how abnormal they are. And what do we do with bone marrow aspiration? We check their platelet count beforehand. We educate them about the discomfort or the pain that they might exhibit, both afterwards and during the procedure. We hold the procedure site for at least 5 minutes afterwards to ensure that homeostasis has been achieved. And also place a dry sterile dressing, avoid infection, right? And avoid any sort of medication such as aspirin that will cause them to bleed after the procedure. Plasmapheresis, so Quinton was placed. So Quinton is basically like a large central line, okay? So the large central line that can also be used for like hemodialysis, etc. So a Quinton was placed in this patient so that way their blood could sort of be, sifted through, I guess, if you want to say it that way. So plasmapheresis means that the blood, it's like a hemodialysis, they kind of take it out of the body and circulate it in a machine, and it removes the unwanted particles. Okay, so for instance, they can remove things like the abnormal, like white blood cell counts, so the immature white blood cells. So they can sort of separate that and then give the rest of the blood and blood contents back to the patient. So it's similar to like a hemodialysis. He was also started on antibiotics, started on hydroxyurea, and neurology consult was placed. Allopurinol. So remember, what is allopurinol for? That's the uric acid. And why does uric acid circulate in the body with leukemia and chemotherapy treatment? Well, because the white blood cells are being destructed, and when they're destructed, they release uric acid. Okay? So HIV tests, blood cultures, they're unsure whether or not he was in CML and blast crisis. So remember, CML, the acute phase, which is that terminal phase, is considered blast crisis. Very poor prognosis with this. Or if he was in acute myeloid leukemia or chronic lymphocytic leukemia. They weren't too sure, but those were the options they were going through. So he was started on Gleevec, so that's the, aggressive chemotherapy treatment. And remember, with Gleevec, we want to assess for tumor lysis syndrome. He ended up spiking a temp of 103 2 days later, and in 24 hours, he ended up having a head bleed and was declared brain dead and was withdrawn with care. So head bleed, most likely related to abnormal platelets. If we had more information here, again, this isn't my case study, so I don't know all the details, but with the current treatment he was undergoing and the progression of the disease, my thought is he probably had low platelets, more abnormalities within his blood counts, and it made him more susceptible to, the bleed in his head. To talk a little bit about lymphoma. So lymphoma is a solid malignant tumor which originates in the lymphatic tissue and spleen. All right, so the lymphomas sort of start in a lymph area and they spread through the lymph system to other areas. Okay, so we have Hodgkin's lymphoma. And Hodgkin's lymphoma is classified by, determined by something called a Reed-Sternberg cell. And you can see here in the little picture, so a normal lymphocyte looks like these little circles, these little dark purple circles. And then a Reed-Sternberg cell is this very large, abnormally shaped cell. All right, so this is found in the lymph tissue, and that would be with Hodgkin's lymphoma. And then we have non-Hodgkin's lymphoma, so we'll talk about the two. Lymphoma's high cure rate. It may be found by X-ray. They may see a large mediastinal mass. So remember way earlier on in the beginning when I talked about finding large masses by X-ray, maybe they've been complaining of having difficulty swallowing for some time, and it's all related to this large lymph mass in their chest cavity. They may also have a bone marrow biopsy, okay, or aspiration to determine whether the marrow is involved. And as I mentioned earlier, it's spread via the lymph system and ends up affecting multiple organ systems within the body. Treatment would be aggressive chemo, and it can be staged. So stage 1 is your, highest chance of curing the disease because it's sort of like the most basic form, if you want to call it that, because stage 1 is only one single lymph node. So it's only in one little area. So if they can remove that lymph node and treat them, they have an 80 to 90% cure rate with that. But as you see, it goes forward to stage 2, stage 3, and stage 4, which would be the worst stage. Stage 4 is disseminated involvement of one or more organs with or without lymph node involvement. So this means disseminated, meaning all throughout the body. Basically, at this point, it is systemic. Your non-Hodgkin's lymphoma, so remember you probably recall this from HIV lecture, right? So when patients sort of progress to AIDS and they have the risk for the opportunistic infections, etc., non-Hodgkin's lymphoma is one of them. So it often is found in patients with immunosuppression, such as your AIDS or organ transplant recipients, and some autoimmune disorders such as Sjögren's syndrome, which is a syndrome where the connective tissues in the body are sort of more tight and they become very dry. All the oral mucosa, mucous membranes are very dry. So just knowing that it's immunosuppressed patients and autoimmune. There's no definite known cause, and over the last 20 years, we've seen an increase in non-Hodgkin's lymphoma. Age over 60 and men more than women would be some other risk factors. So with Hodgkin's lymphoma, treatment plan would be, discussing the stage of the lymphoma, if it is curable, or if you should start to have conversation about palliative care, right? So palliative care meaning just kind of help to take care of the symptoms, okay? Hodgkin's disease most often affects young adults. And if they're talking about undergoing, aggressive treatment and they are young people, then one thing to talk about is induced sterility, basically saving, some of their sperm in a sperm bank, because when they undergo all of this really strong, aggressive treatment, and they get really strong chemotherapy, radiation, and if they need to have bone marrow transplants, etc., that can really damage their sperm in their body. So if they're young people who plan to have a family someday, if they're cured from this disease, something to talk about is the therapy-induced sterility. Also, just assessing their support system. They can go through periods of remission and reoccurrence. So who is going to be there to support them so that they sort of, aren't alone going through all of this. So bone marrow transplant, so it can be used for both lymphoma and leukemia. And basically, the patient receives an infusion of stem cells or bone marrow cells through a central venous catheter. So that is a central line, a very large IV. Okay, so you can see here it's similar to getting a blood transfusion. And I did put in the bottom here that it can be allogenic or autologous. So allogenic simply means that a healthy donor who matches the tissue antigens of the recipient donated their bone marrow, all right, so that they could get the bone marrow cells, transplanted to the recipient. So it has to be someone who does closely match the recipient, and that can be a family member. Remember how I mentioned with My Sister's Keeper, that movie, the parents ended up having another child specifically so that they could help to treat their firstborn child with the bone marrow transplants, etc. So it can be a family member, or it can be, someone just who is off the streets, who's donating, and they closely match the antigens of the recipient. So basically the point I want you to get is allogenic is donated. Autologous, so that's patient's own bone marrow, okay? So remember when I briefly mentioned earlier, like the plasmapheresis, so when Patients get hooked up to a machine that is similar to hemodialysis, and the blood is sort of filtered, and the stem cells can be removed, okay, bone marrow cells, so those can all be sort of removed and kept aside. And what they do is they end up freezing those cells. And when they freeze those cells, the patient will then have their chemo, their radiation, they really have their aggressive treatment. And when they're in the remission phase, meaning that they're sort of cleared from their cancer cells, when they're in that remission phase, they can get their thawed stem cells, so they thaw it after it's been frozen, and they transfuse it, again, similar like a blood transfusion, in hopes that it will help to stimulate a positive effect of their immune system and their bone marrow function, that it will help to stimulate proper functioning, proper cellular replication, and build a healthy immune system again. Okay? So they can, when they're receiving those treatments with a bone marrow transplant, especially if it's allogenic, someone who's donated it, you want to watch for signs and symptoms of, chest pain, shortness of breath, flushing, like flushing in their face where their face kind of gets reddened, like beet red, funny taste in mouth, chills, fever. All right, this may indicate symptoms of a reaction. So it's very similar to like a blood transfusion. Complications. So graft versus host disease. So this really, it can happen, in anybody who has received some sort of transplantation, but more commonly occurs in severely immunocompromised patients. Okay, so with severely immunocompromised patients, if they have received, say, this bone marrow transplant, and those cells come into the body, and they end up recognizing this recipient cells as foreign, they're going to attack. Okay, so the donor cells end up attacking the recipient's cells and the recipient's tissues in the body. Okay, so some common signs and symptoms, initially they may present with a reddened rash on their palms of their hands and soles of their feet, and then it kind of starts to spread systemically all throughout their body, so it becomes diffuse rash. They have a fever. They may exhibit some nausea, vomiting, and diarrhea. Okay, so just remember that these cells that were just transfused into this patient are now attacking the patient's body. And this doesn't happen immediately. It can happen in sort of an acute phase, like sort of within 3 months of the transfusion, or it can happen later after 3 months. And it's just a matter of watching for the signs and symptoms of the rejection. All right. So preventative measures include irradiating blood products to inactive donor lymphocytes. So if you do this, it will help to decrease the risk of those lymphocytes attacking the recipient's body. Okay? So again, another case study, 56-year-old male, schizophrenia, recently diagnosed with B-cell lymphoma form of non-Hodgkin's lymphoma, presented to the ER with hoarseness, dysphagia, a large neck mass. He was intubated, radiology, so the x-ray showed extensive right neck malignant lymphadenopathy. Okay, so that's enlarged lymph nodes, a mass on his larynx, and displacement and involvement of the right carotid artery. So aggressive chemo was started. He received radiation to the area and also palliative care and end-of-life discussions, because at this point, it has really invaded multiple system areas. So you can see here just a picture where they went in here on the right side of the neck to remove the large mass. He's intubated with an endotracheal tube that is here. Okay. So practice case study. So this will be talked about in class. But Susan Clare is 38-year-old female, admitted to the med oncology unit with AML. She has many areas of ecchymosis and petechiae on her skin, as well as generalized pallor. She states she's lost 15 pounds in the last 2 months and often has a low-grade fever. On physical assessment, you find her liver and spleen to be enlarged on palpation. So what lab results would you anticipate due to her ecchymosis and petechiae? Well, that would be your CBC, so your complete blood count. So this will allow you to look at their white blood cell count, the red blood cell count, and their platelets. So why would it be important to inspect her gums and her teeth? And why is her liver enlarged? So think of the risk for bleeding and inspecting her gums and teeth. So they may have bleeding gums. Okay, so with decreased platelet counts, they could have bleeding gums, and that would be your sign and symptom that someone is exhibiting bleeding gums. They don't know why. You want to check their platelet counts because most oftentimes their platelet is going to be low in instances like this. And then the liver is enlarged. Remember, when I talk about sort of those abnormal cells sort of taking over and infiltrating the liver, the spleen, everything becomes enlarged. So it's due to the proliferation of new cells. All right, so it can be enlarged and painful, and also the bone pain can occur because of the expansion of the bone marrow. So a child with leukemia will be undergoing an allogenic bone marrow transplant. So allogenic, meaning that it is from a donor. When teaching the parents about the procedure, which information should the healthcare provider include? Select all. So the answer is going to be B. So stem cells, they can come from an umbilical cord, okay? When you hear of like those stem cell banks for umbilical cords, that's kind of becoming more popular these days. So it can come from that. D, they might need periodic transfusions. And E, it's possible that the donor cells will attack your child's cells. All right. Is preparing a patient for a bone marrow aspiration. Place the following steps in order. So what would you do first to last? So you're going to verify risks and benefits, right? Explain everything to the patient. Then you're going to get consent. And then you'll give your sedative for patient comfort, pre-procedure timeout, and then monitor for bleeding. All right, so that's it for the leukemia and lymphoma. Biggest things are your risk for infection, risk for bleeding. All right, you should sort of understand the different types of leukemia, the 4 different types, and also your general side effects and general treatment for each. I did put together a sort of condensed chart all on one page, so that way it will help you to visualize the difference between each type of leukemia. And also, I printed out a really nice picture of all the different clinical manifestations that patients can experience with leukemia systemically. And it's also important as the nurse to think about, okay, what are my primary or priority interventions for these patients? What complications am I going to observe for? What medications am I expecting to give for these patients? So those are sort of your important things to know, and I hope that the chart that I have posted on e-learning will help to sort of put it all together for you in one place so that it's easily read and you can see the differences and sort of help to start your thinking process as to, okay, what am I, the nurse, going to do for these patients, and why am I going to do this for these patients? Okay? So if you have any questions, feel free to reach out to me. Thank you.